You're listening to Medscape's In Discussion series on cancer survivorship, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Partridge, Professor of Medicine at Harvard Medical School, Vice Chair of Medical Oncology, founder and director of the Program for Young Adults with Breast Cancer, director of the Adult Cancer Survivorship Program, and Eric P. Weiner, MD Chair in Breast Cancer Research at Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hello, I'm Dr. Ann Partridge. Welcome to Season 2 of the Medscape In Discussion podcast series on cancer survivorship. Today we'll talk about financial toxicity. First, let me introduce my guest, Dr. Jeffrey Peppercorn. Dr. Peppercorn is a medical oncologist specializing in breast cancer care at Massachusetts General Hospital. He's also an associate professor of medicine at Harvard Medical School and director of supportive care and survivorship for the Massachusetts General Hospital Cancer Center. He is board certified in internal medicine and medical oncology, and he's here to speak with me today about financial toxicity. Jeff, welcome to Medscape In Discussion podcast.
Thanks so much, Ann. Good to be with you today.
Really terrific to be here with you. And Jeff, we've known each other for so many years, and it seems that it's been fairly recent that you've been really involved in the financial toxicity aspects of cancer care. So can you tell us, A, what does it mean? And B, what got you into that?
This is a fun topic for me, and it starts back when I was on faculty at Duke and had a junior colleague, actually, I think at the time he was an oncology fellow, Yusuf Zafar, and identified a funding opportunity for him through a foundation, the Healthwell Foundation. And we talked about a study that would look at the financial burdens of care. And of course, people have been talking about financial burdens of care for decades. But we designed a study looking at patients who were supported through the foundation and looking at the financial burdens that patients faced just in the chemotherapy infusion, and just characterizing the challenges that patients and families felt related to the costs of care. And I will give Dr. Zafar full credit for coining the term that was used in that paper, I believe for the first time in print in 2013 in The Oncologist, financial toxicity. As I said, it wasn't the first time people had talked about burdens of care, and we'd even written papers about the full toxicity of cancer therapy outside of the traditional things we think about. We coined that term in that paper, and it really caught fire and I think, captured people's imaginations by making it analogous to the toxicity that you and I are very familiar with. Then we give a drug and patients experience side effects. And by talking about the burdens people experience in terms of toxicity, it seemed to attract national, international attention. So there's now been well over 1,000 papers on this topic. And we're still, I think, in the early days of trying to recognize it, move it into our care, and figure out how best to manage it for our patients. And so since that time, I've remained engaged in research in this field. I've written many other papers with Dr. Zafar on this topic. And the last thing I'll say is that I'm editor-in-chief of one of the oncology journals, JCO Oncology Practice, where well within our scope is financial toxicity. So now I have the privilege of reading a lot of the research that's being done in this area. It's been great to watch the field grow.
I'm glad you brought up your editorial role, because I think it is where the rubber hits the road often in oncology practice. People can't get care if they can't afford it, unfortunately, and there are many different reasons for that. So Jeff, you're not new to it by any standard. You've just clarified it's kind of new to all of us to actually be incorporating this into cancer care, or at least as physicians paying attention to it. It's always been an issue in cancer care, but how is it changing now? Why is this an important thing in 2024 when we're thinking about cancer care more so than it's been in the past?
I mean, I'm not sure it's unique to 2024 or recent years, except that we keep having so many advances in oncology, which is, of course, a great thing. There's more and more that you and I can do for our patients in clinic, and not to mention our colleagues. And you and I are both breast cancer clinicians, but all of the advances we've made in treating so many different types of cancer. But it comes at a cost. New drugs and new interventions can cost a lot of money, particularly in the US. Some of that is due to the prices that are set for these drugs, which is really beyond what anyone can afford to pay. And some of it is just that I think innovation always costs money. But there's a big challenge because we want our patients to get access to these therapies. And if no normal mortal can afford to pay for them, how does the cost of care not threaten access? And then particularly, I think one of the challenges that we face particularly in the US, although this is a global phenomenon, is the mismatch between the cost of care and insurance coverage. So we've done much better in recent years. In some ways, maybe it's better in 2024 than it was 15 years ago before the Affordable Care Act. But still, patients face a growing share of the cost of care. There's more and more of the costs that are being pushed to the patient, called cost sharing. People refer to as having skin in the game, as if patients can decide for themselves whether or not they want to get treated for their cancer, which of course is not true. But anyway, there's a high burden on patients and families. And so that's why I think it's critical, as we have all these advances, making sure that patients can take advantage of the care of 2024.
You make a good point. This is not a well baby check that you're coming in for a hangnail, which you can take care of on your own. You have to go see someone for your cancer care. These are not choices, right? A very, very good point. I'm just thinking about the toxicities, and we'll get into kind of what we can do as clinicians, what we need to know about, but defining it, can we get a little into the scope? So when we think about financial toxicity, we all immediately, I think, go to what's the copay on the oral medicine that's going to keep your cancer at bay, and it's the hot new drug. But can you talk a little more about how the financials creep in for individual patients?
I think I can address that. So this is basically the costs of care, which you're alluding to, the direct costs, and then the impact of those costs on the patients. And it's the intersection. And, one person can have what may seem to somebody else like a relatively minor cost, but it may be the difference between them taking their drug or not, or skipping something else that's important in their life. So how it affects each individual is different. What is the full scope of financial toxicity, if we want to define that as the burdens of care and the impact? So it's not just the cost of the drug or the cost of the surgery or the cost of the radiation. It's really a combination of the patient's direct out-of-pocket costs. So to say nothing of what it costs society, that's also a very important issue, but that's a little bit separate when you're thinking about the individual patient in front of you. What is their direct cost? Then what are their indirect costs? What is the cost of travel to see us in clinic? What is their cost of caregiving if they need care for an elderly parent or child? What about the cost of missing work to come in on a weekly regimen, or some regimens that are even more than weekly? Changes in employment, and then overall, in the process of having cancer, which of course can be a lifelong condition, just the depletion of assets that occurs as a result of the illness. So that cumulatively is what we mean by financial toxicity. And that's sort of the enemy that we're up against here, that we would like to address and minimize as much as possible.
That's very, very helpful, because I think many of our listeners, and I didn't for a long time when we started talking about the term, even though you had seen it before, the problem, I didn't really think about, as I said, the babysitter or the loss of that day at work for a person who's making minimum wage and won't make the money that day because they didn't go to work. And then, as you alluded to, the downstream repercussions of those losses over time and how that can impact on housing and the ability to take better care of their children in the long run. I mean, there's so many ramifications of this. It really, really is quite a toxic situation, even for people, I think, that are reasonably well healed, I would imagine.
I mean, there are drugs out now that cost $400,000 a year. So that's not something that most of us can afford. And many, many drugs that if you place them out there, $50,000 to $100,000 a year of our mainstay drugs. So it's just, I think without health insurance coverage, and that's maybe one point to emphasize here, we all need help paying for the cost of cancer care. And I want to just come back to this idea that it's really, both in our system and other systems, it's an artifact. And that's what's so frustrating about this. It's not inherent. If I give capecitabine, not everybody has the same side effects, but I know the risks of toxicity, right? There's GI toxicities, there's hand, foot, skin changes. It's inherent in the drug. And the effect on the patient might be modified by how closely I monitor it and what I do to try to help prevent those issues, but it's inherent in the drug. Financial toxicity of capecitabine is not really inherent in the drug. It's a combination of what a company decides to charge for it and then what the insurer decides to pay. And it's the gap in between where the patient gets squeezed. So that doesn't remove the responsibility of the clinician from addressing it, because it's every bit as real and sometimes every bit as damaging as those physical toxicities. But that's what we're up against here. And so I think as a clinician, we need to know how to identify it, how to try to monitor it, and then ideally, since we're experts in this area, push for policy solutions that will help reduce the problem as much as possible.
Yeah. So what can or should clinicians do to even evaluate financial toxicity in their patients? It's impolite to ask these questions. I mean, I'm kind of joking about that, but how do we address that with our patients without making them feel bad?
Yeah, there's some good research on this to guide us that most patients appreciate being asked about this topic. That does not mean that most people actually want to talk about it. They're okay with being asked the question. We talk in so many ways about individualizing care. This is another area where you need to individualize care. I think there's no great excuse for not assessing a patient's interest in the topic and asking a simple question like, are there any financial issues you want to talk about? Or are you able to get your medications? Some patients, you're right, will be concerned if you raise questions of finances that suddenly, are you talking about giving me less good care if I can't afford it? So it takes skill, just like the rest of our jobs take skill in being able to navigate that. But I think in general, we need to be willing and able to approach these questions. ASCO has come out years ago, more than 10 years ago, sort of charging us that high quality care involves conversations about cost, at least being open to the conversation. And ESMO similarly, even though the European countries have national healthcare, it's a problem there too, and just came out with very similar guidelines, really just published, talking about the need to discuss this with patients. So I think it's a global issue.
I'm just wondering, are there ways that we could use technology to help us here? Many are incorporating PROs or patient-reported outcomes into patient care when they come in to assess their other symptoms. Could that potentially be a way to manage this? And has anybody studied that, at least to surface the question?
So definitely there's potential for technology to do this. And there's actually been published studies, including in JCOP. I think it was like a financial burden order set. So you can build in ways to do this using the EHR for screening for financial toxicity. If you want to be as precise as we can be, it's worth mentioning this conversation, the COST tool. Researchers in this field will be familiar with, but I assume most clinicians will not be. It stands for Comprehensive Score for Financial Toxicity. But basically it was developed out of UChicago, and it's now 12 questions that you can ask. And if you want to do research in this field, that's one of the most popular things to use. On the other hand, we have so many things we have to talk to patients about and ask them about. We can't either ask them, or even if you did it through the EHRs, they're checking in, if everything that's important, insomnia, sexual health, cognitive toxicity, if everything gets a 12 question thing, patients will spend their entire day filling out our questionnaires. And then the question is, who's going to read them and how do you synthesize it? So I would say this is actually an active area of research. I don't think anybody has come up with the one gold standard single question or two questions, but I would also say this is not rocket science. Just asking the question, and then if they flag positive, you can dig in more in terms of what does that mean to them. I wrote down for myself, I don't have the exact language memorized, but the EORTC has a single question involved in this larger quality of life survey that is, in the past week, has your physical condition or medical treatment caused you financial difficulties? And I don't think you need to remember that exact language. You can just basically say, related to the cost of care or your cancer, are you having any financial troubles that you want to talk about? And in some ways, it may be better, getting back to your original question about can we use technology, it may be better to have that be in a screening questionnaire than the first thing I say to a patient, or even the second or third thing I say to a patient when I'm in the clinic room. Let them answer it on paper. Let me see that before the clinic visit so I know to address it or not. And then if it's one of the things that they flag, then we can go there. And I think if you do that, you'll realize that maybe a third of patients, this is what studies have shown, a third of patients are concerned and suffering some form of financial toxicity and do need our help.
Well, it also normalizes it, right? If it's part of a standard battery, then I haven't just selected it because I'm looking at you. It's a standard battery, and it may take a little bit of the feeling of social acceptability out of it and a little more of a, oh yeah, this is a problem and I can talk about it here.
I think that's a great point. If you don't have this set up yet, I wouldn't want to discourage someone from just asking the question. Just reflecting on my own practice, I think it is preferable to have it as part of a screener.
So, okay, let's pretend I start doing this regularly, and I will try, and I do try when I see it, although you can't always judge a book by its cover, we know, right? People don't always tell you if you don't ask, and as you noted, we're busy in clinic. So let's say they screen in or I ask and they tell me, yes, I'm having issues. What can we do? What can we do to help patients who say they're having issues or to help them avoid issues?
That's a hard one. And it's sort of like some other areas that we're sometimes afraid to ask about because we're not sure that we can help. And particularly as a clinician, I'm trained to treat breast cancer and I'm okay at managing nausea and sometimes pain, but we start to get further afield and I may not feel totally confident. I'm sure that we're just not trained in this in medical school or fellowship, but there are things we can do. If you take a step back, some of it is just, if you know this is a concern for patients, finding out if they're actually taking their medications that we're prescribing. Usually we've got a pretty good system to alert us to this ahead of time. I've had patients facing a $3,000 copay, and I certainly didn't expect them to pay that, but we may not have discussed it at the time of prescription. And ideally, and increasingly in our system, they're getting automatically, specialty pharmacies and others are picking this up and connecting them with patient assistance programs. So I've had patients go from, oh my gosh, I can't take this, 3,000 to, hey, fantastic news, I've no copay at all. So that's no magic on my part, but that is working within a system that can connect people to resources. So what can we do to help our patients? I think just raising the topic and putting it on our agenda, even if it's going to be something that's going to be challenging for us, certainly helps to be aware of it. We can sometimes adjust the plan. You don't have to be the expert in financial navigation. I'm certainly not. But if I recognize that a patient's facing high copays for their scans or labs, we often have some discretion. Can you get a scan every 4 months instead of every 3 months, or even every 6 months if they're doing well? Can you decrease the frequency of visits? Can you move some visits to virtual just to save them an hour of transportation on either end, which may be the difference between them taking time away from their job or needing childcare or something like that? So I think there are things that are well within our control that we can do. And then we certainly need to rely on our colleagues and the team that's required to take care of patients with cancer. And that's social worker or financial service specialists at most of our clinics and institutions. This has been well studied. So when people have implemented systematic screening and then connecting people to social work, they find that they can save in a small number of patients, 40 patients, for example, they can save over $1 million in the span of a year. So it's a massive impact that you can sometimes have. And I think some of that is because the high cost of drugs and they get connected with a patient assistance program. And it's worth mentioning, it's actually been one of the focuses of my research, these copay assistance foundations, which is a whole nother interesting topic of one of the Band-Aids we have in our system. But fortunately, there are these Band-Aids that can step into the gap between the cost of drugs and insurance and help minimize it for patients.
Tell me a little more about what research you're doing in this space.
There are these foundations, they're nonprofit foundations for patients with high copayments for any drug, cancer and other medical conditions. They do some assessment of need and then they help pay the copayment, and they sometimes help with premium assistance. So, one of them is the Health Well Foundation, but there's many others. And this is sort of an understudied aspect of our healthcare system. And there have been some critiques of these groups because what many of them do is they take large donations from pharma, not going directly to the patient. It's not a manufacturer program, but pharma may, for example, give money to a breast cancer fund. And then the patient who has breast cancer, who has any drug that's expensive, whether it's made by that company or not, it'll get covered. But it is a little bit of pharma pays in, the money goes out to patients. And so some people have been concerned, hey, is this just propping up the cost of drugs? And is this really helping people? Now, as someone who's kind of stuck in the middle as a clinician, I think that's an interesting point. And I guess the argument is that if you took away this Band-Aid and other Band-Aids, there'd be such screaming in the streets that the whole system would have to change. But I'm a little skeptical about that. And so my research has just been to define the Band-Aid better. So we at least understand what it is. As there's political conversations going on, should these be more regulated? Should we get rid of them? Should we do something else? Great. I'm all for any solution that gets drugs in the hands of patients who need them. But since this is a big part of our healthcare system right now, we've done some research trying to study this. And one of the things where it's under review right now, a survey of 1,500 patients from around the country, just asking them, what was their experience? What led them to require copay assistance? What's their ongoing level of need? So these are all people who have copay assistance. They're getting help paying for one drug, but what are their ongoing levels of need? And I guess one of the headlines there in our survey, these were 90+% of people on Medicare. And one of the questions we asked them was, did you expect your insurance to cover the cost of healthcare? And they did. And I would have expected the same too. I'm an expert in breast cancer. I'm not an expert in health economics, but I kind of thought that by the time you turn 65 or whatever age you start Medicare, that even if the rest of our system is not perfect, at least then healthcare is covered. But as many people listening probably know, it's not. And under Part D, people can still have very high co-payments. And that's what the public thinks. So in all these public debates we have over healthcare, people think that once they get older, which is when you tend to need more medical care, including cancer care, that at least then they'll get the care they need. And the fact is that's not true. We have massive gaps in our system. So you and I can screen for it and try to help people and connect them to programs like these charities, but that is a major policy issue that still needs to be addressed.
Fascinating. And I'm glad you're studying it. And what would you say if you were to have a crystal ball and say, I know where this field is going? What do you think? Where are we headed? Is it going to be one Band-Aid after another, or is there going to be some big explosion and changing of the system?
I think there's three things that are coming in the future. One is, I think we want to try to optimize screening. And as you and I got into that conversation, what's the best way to do it? Is it asking in clinic? What's the best way to capture it as efficiently as possible? So screening research is still needed. Navigation research is a major gap. There's a lot of studies going on. And as a journal editor, again, this is what we're most interested in: interventions to address this problem and show that they made an impact and that they help patients. And then again, policy. And it's worth, maybe in our last minute, it's worth flagging that one of the policies of the Inflation Reduction Act that's going to be rolling out next year is that copayments were capped at $2,000. So most people have not even seen the effect of this yet, but copayments for Medicare Part D drugs is capped at $2,000. This is compared to what now many people are facing $30,000, $40,000 of cost. So I think that's going to have a big impact on solving this in this country for people, but it will still be a challenge.
Well, that is very exciting. And thank you for highlighting that law, which will now help us all to protect our patients against the high prices of copayments. Jeff, it's been terrific. It's always fun to connect with you. Today, we've talked with Dr. Jeffrey Peppercorn about the financial toxicity of cancer care, a wide-ranging, very impactful topic. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on cancer survivorship. This is Dr. Ann Partridge for the Medscape in Discussion podcast.
Thanks for listening to Medscape's In Discussion Cancer Survivorship podcast series with our host, Dr. Ann Partridge. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on cancer survivorship.